Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our colorectal cancer journey. And this time we have an awesome episode for you guys talking about early onset colorectal cancer. We have a guest on our show, one of our really good friends, Chris Cann, who's an assistant professor in the Department of Hematology and Oncology at Fox Chase in Philadelphia. Guys, what a great episode this was.
Yeah, super fun time recording it. Chris and I are very good friends, and it was good to see him virtually, and really good to see all of his accomplishments and really talk through this really important emerging field.
Yeah, it's such an important field, colorectal cancer, and unfortunately many other cancers as well. So I'm glad that he's putting his mind towards it.
Absolutely. So without further ado, let's roll that show. Guys, we are so excited to have another very special episode for today, and we have another guest. Our really good friend and colleague, Dr. Chris Cann, is joining us all the way from the city of Philadelphia. Chris, welcome to our show.
Hey guys, so good to see you all. It's been a long time.
It's been a long time. It's really, really good to see you. Guys, just so you're all aware, our listeners are aware, let me tell you a little bit about Chris, and we'll turn it over to him to tell us about himself as well. So Chris Cann is an assistant professor in the Department of Hematology Oncology at the Fox Chase Cancer Center in Philadelphia, and he has a particular area of interest and clinical focus in gastrointestinal cancers. And in addition to this, Dr. Cann has already made a name for himself in the early onset colorectal cancer space, having published and presented on this on a national level, despite just being in his first year as an attending. So Chris, great job. I actually saw that your name popped up in a local news article too. So you are making your way through the media as the expert in this field, and we're really excited to have you on the show.
No, I really appreciate you guys inviting me on, and it's definitely one of the passions of mine for sure.
And the best part about all this, listeners can't see this, but all those accomplishments, Chris right now is wearing a Philadelphia Eagles jersey.
That's right.
Doesn't know that Jalen Hurts isn't that good. I'm just saying it. Sirianni's not, I don't know if he's the answer. I don't know if Hurts is the answer. I'm just throwing it out there.
Hey, all I got to say is go Birds. That's all you got to know.
I'm also rocking my green because go Birds. And so it looks like it's 2 against, Vivek, unless Dan wants to pick a side. I don't know. He's rocking his California gear.
Yeah. Oh, man.
So, Chris, in our usual fashion, we always like to start these episodes by turning it over to you and asking you to tell us one fun fact about yourself.
I guess one fun fact, well, maybe 2. Currently living up in Philadelphia with my 2 favorite girls, my wife, Lena, and then also my favorite girl, Bella Mushroom, who is a 100-pound Bernese Mountain Dog. And then one fun fact, I don't know if I've ever told you guys this, but I'm a 2nd-degree black belt in a martial art called Tung Soo Do. And so I don't know if I ever mentioned that.
Wow, I didn't know that.
Yeah.
Chris is a bunch of swords too.
That is true.
He's a man of many talents.
Chris, what is the country of origin of that type of martial? I've never heard of that before.
South Korea.
Amazing. How cool.
Yeah.
Well, we have a really awesome show. As you know, we're in the midst of our colorectal cancer series right now, and it was just fortuitous that there was a New York Times article that was recently published about this. And so once again, even though this is not new news to those of us that do this, the concept of people getting cancer earlier and earlier, especially colorectal cancer, certainly has taken a little bit of spotlight in the lay press recently. And so we thought it'd be really fitting to have someone like you on our show to just talk to us about what's going on and shed some light on this for our listeners. So if it's okay, then, I'll just kick us off. Maybe I'll throw out the first question to you all, and then we'll go from there. Does that work?
Sure. Sounds good.
Okay. So as I mentioned, there was this recent New York Times article. And, as I was doing a little bit of reading about this, especially in light of that article, I saw that from 2011 to 2019, the rate of colorectal cancer is increasing by almost 2% per year in people that are younger than 50, which I thought was astounding. I mean, that number just seems really, really staggering. And so, I'm sure we'll get to more of this in just a second, but I wanted to ask you from your experience, is there anything different when it comes to the characteristics of these patients and their type of cancer? Like, do they have genetic predispositions? What is the sidedness of this disease? Does it look different than colorectal cancer that we're seeing in patients after the age of 50?
No, yeah, it's great questions. And so I'll kind of allude to the percentages of how the drastic increase is, and then kind of go into that a little bit. And some of the more marked percentages that I like to reference is, there's an estimation by 2030 that rectal cancer incidence will rise by 124% and 46% within the 20 to 34-year age group and the 35 to 49-year-old age group, respectively. And so to put it another way, those that are born in the 1990s have about a 4 times increased risk of developing rectal cancer and a 2 times increased risk of developing colon cancer relative to those born in the 1950s. And this trend of just increased malignancies within the early onset population is not necessarily isolated to colorectal cancer, but we're seeing it in gastric cancer, pancreas cancer, and bile duct cancers as well. From the presentation and the differences that we can see between what we call average age onset versus those that are early age onset. So the majority of these patients are sporadic, actually. So only 12 to 16% of early onset colorectal cancer harbor a pathogenic variant that would lead them to develop cancer. And so 8% of early onset colorectal cancers are Lynch syndrome. But otherwise, the majority of these patients are sporadic in nature. From a genetic standpoint, somatic differences have been observed, but right now, they're mostly subtle without the ability to really intervene upon these somatic differences. So for instance, early onset microsatellite stable cancers have more TP53 mutations, and MSI high colon cancers have more APC and KRAS mutations relative to average onset, but really not a ton of significant differences. But this is one of the things that a lot of researchers are working on. When it comes to symptoms, the most common symptoms that are present in these patients are blood in the stool, fatigue, and abdominal pain. All of those are about 2/3 of patients. In a very large survey of over 1,000 patients and survivors, the unfortunate thing is 41% of patients waited over 6 months before seeking medical attention. And over 2/3 of patients saw 2 or more physicians prior to their diagnosis. So there's a disconnect in the awareness of this phenomenon, both from the educating the population about this problem, and also from a physician standpoint of understanding what things to look for. Clinically, early onset colorectal cancer patients present differently than older onset colorectal cancer patients, sometimes exhibiting hematochezia for longer periods of time. And as I mentioned, having multiple office visits and this delayed time to the onset from symptom to diagnosis. From a sidedness standpoint, the majority of patients are left-sided. So about 76 to 80%-ish relative to early average age onset's about 60%. There, from a stage of diagnosis, predominantly there's a higher prevalence of stage 3 disease on presentation. And there's controversial data on whether or not there are higher rates of poorly differentiated tumors versus other differentiation of the tumors. But what we really don't know is if the biology is truly different, if there's higher rates of poorly differentiated tumors, or is there a difference in the acceleration of this disease that's different from average onset patient.
Yeah, I think all those things are really important, that seems to be there's a delay in diagnosis here, right? That, obviously we're not screening these younger patients like we do with the older population. So maybe you are seeing more stage 3s at presentation. And what will be interesting and what kind of fits with what you were telling us about the molecular landscape, there's a lot of TP53 mutations. Those are inherently going to be higher risk tumors that probably proliferate faster, maybe poorly differentiated. It'll be really interesting to see how the research pans out here. One thing, so Chris and I were in fellowship together with our good friend Shakti, who's co-attending with me right now, and we always got Taco Bell. Taco Bell is the best. Get that cheesy gordita crunch. Shakti and I do it every week still, and I bring this up because there's environmental factors that clearly there's probably something at play. We think traditionally metabolic syndrome and smoking are those risk factors, but it seems like some of these colorectal cancers are occurring in otherwise healthy individuals that are younger. Some of them are athletes. So what are your thoughts on the role of environmental factors and how do you think this is all playing in the development of these cancers?
Yeah, no, it's a wonderful question, and it's one of the biggest questions that is right now is out there in this field, is trying to understand what factors are really influencing the rise in this incidence. And so, one thing that I'll touch on first, I guess, is the fact that there's an association between obesity and early onset colorectal cancer. So there was two big survey studies, one with 85,000 patients that were all females that had no evidence of disease at enrollment. And it found that those that had BMIs over 30 had a significantly higher relative risk of developing colon cancer that was actually nearly identical to those in that patient population that had a family history of colon cancer versus those who did not have a family history of colon cancer. And then there was another survey study of 64,000 boys out in Copenhagen, actually, that showed that those who were overweight at age 7 and then tested again at overage at age 13 had a hazard ratio of 2.62 for developing colorectal cancer relative to those who were normal weight throughout that time frame. But when it comes to the more of a pathogenesis component of this, I think one of the biggest areas of research that's happening right now is with the microbiome. And so two things are being studied pretty significantly. One is antibiotic exposure, and other is high-fat diets. So from an antibiotic perspective, where a lot of this is mouse models at this point, but from what we can tell is that the microbiome is normally dominated by obligate anaerobes. I know this is going back to microbiome, which I admitted was not that great.
Why are you doing this?
I'll try it. I know. Just
Chris, why are you doing this, man?
Hear me out. So as I'm trying to learn this myself, so the obligate anaerobes are dominant most of the time. And so facultative anaerobes have limited beneficial functions to the host, but the microbiome community shifts from obligate to facultative anaerobes, resulting in this host inflammatory response. And so this is seen with this antibiotic exposure as well. So these antibiotics deplete the bacteria, the normal bacteria that are butyrate producing. And ultimately, to skip all the nitty gritty of these things, it allows an increased nitrate levels to be produced by these facultative anaerobes in the colonic lumen, along with an increase of anaerobic glycolysis, leading to inflammation and lactate production. So overall, what we're seeing is that we're seeing this increase in inflammation with antibiotic exposures. And so outside of just mice, when there was a case control study of incident cases in the UK between 1989 and 2012 and 29,000 CRC cases, the risk of colon cancer increased after antibiotic use in a dose-dependent manner, especially with penicillin is what they were able to find.
That's really fascinating. The risk factor epidemiology studies, these are really well done studies. And I think this is going to be really, really important for this population moving forward. So that's all really interesting.
And I think the one other thing, the high-fat diet that we see in the United States increases the amount of trimethylamines by the gut microbiota, which ultimately increases this inflammation. And so by doing so, similar to antibiotics, increased inflammation lends to presumably an increased risk of developing colon cancer down the line.
And that's pretty intuitive, right? A lot of other cancers, we see chronic inflammation being a huge driving force. And so I guess just kind of identifying some of those sources of chronic inflammation in the gut is going to be really important. When you're reading through some of these studies regarding early onset cancers and early onset colorectal cancer, one phrase you come across is birth cohort effect. Could you help explain what that means?
Birth cohorts are essentially generational differences between patients. So patients born in a certain time frame will have different exposures than those of a later or earlier time frame. And so what we're potentially seeing here is that patients born, let's say in the 1950s, as I referenced before, that didn't have the rise in early onset colorectal cancers relative to those born in the 1990s, there seems to be some type of exposure that is occurring that is different from those in the 1950s, lending these patients to develop cancer at an earlier age. And so that's where I really think it derives from. And whether or not it's antibiotic exposure, high fat diet, or something where we still don't know, being able to compare generational differences is very important so that we can potentially identify what differences there are and then find out that's the underlying cause.
That's really interesting, and that's a good definition for people to know, especially if you're interested in this kind of work. And as we're highlighting here, it's certainly very, very important work. Chris, as a follow-up to this, I mean, surely, I think you've convinced me that the incidence of colorectal cancer is certainly rising in the younger patient population. But could you comment on the outcomes of these patients? Are survival differences visible between patients that have early onset versus average onset colorectal cancer, or is that more or less the same?
So earlier data indicated that overall survival patterns in young patients were no different than older individuals that started standard chemotherapy. But more recently, they determined that youngest treatment naive metastatic colorectal cancer patients actually fared worse with poor overall survival versus the average age onset. So one study in particular, in those that were treatment naive and metastatic, younger patients had a 19% increased risk of death and a 22% increased risk of progression of their disease. So it is possible that these diseases are a little more potentially aggressive, though the one thing I will say is when it comes to the presentation of disease, that delay in diagnosis is I believe one of the big factors that lends patients to be in a tougher spot when they're diagnosed. So recognition of the hematochezia, recognition of the fatigue that's been chronic, and seeing your doctor or advising your patients to get that colonoscopy done is going to be really important to potentially improve these outcomes.
So important. Remember, iron deficiency is never normal.
That's right. That's right.
Just investigate.
Yeah, I think this is really interesting. So my wife in GI, it's good. She loves her colonoscopies, loves doing it. Obviously, what's really interesting for her is in her clinic. To what you're saying, it's a new the GI doctors, the gastroenterologists are so vital to this because they're the first line of defense to make this diagnosis. And I do wonder if we do have the molecular landscape of these tumors can be really important because if there are more undifferentiated TP53 mutated colon cancers, that would explain the difference, right? It may not be this lag in diagnosis. It may just be the genomics of the exposures, but it'll be interesting to see how that shakes out. And the early recognition, I think that you keep on stressing is really important. I hope our listeners really take that home. So one of the other things that I was wondering with early onset colon cancer, are there differences between trends in males and females? And what about differences in racial backgrounds?
So males and females, the data doesn't really show that much of a difference, but from the different racial backgrounds has shown some differences. So the proportion of individuals with early onset colorectal cancer is historically twofold higher in those of non-white racial/ethnic groups. And the survival is significantly worse among non-Hispanic Black patients versus non-Hispanic white patients, even in early stage disease. And it appears there are certain factors that may be contributing to this phenomenon. So the first is health insurance coverage. This contributed to most racial disparities in the receipt of guideline concordant care. And it's actually been shown that Black individuals with early onset colorectal cancer have an increased time to adjuvant chemo initiation, and rectal tumors have an increased time to neoadjuvant chemoradiation therapy and radiation completion. So definitely some disparities there. And one of the things that I thought was very interesting was what we're finding is that 92% of the overall, what we call the early onset hotspot counties in the United States that are seeing more early onset colorectal cancer patients are actually in the southern United States. These patients are most likely to reside in that area, have a larger proportion of patients who identify as Black and are more physically inactive relative to other populations within the United States. So I thought that that was something, although there's obviously no causation in any of these observations, but definitely something that we can see that the disparities in care exist and persist through into this early onset colorectal cancer space as well.
I'm so glad you talked about this. And we can do all the research we want. We can figure out how to cure these diseases. But if we can't deliver that care equitably and effectively to all communities, it like what are we really doing? We can't help people if we can't figure out how to do that. Thinking about trends, still, you mentioned the high fat Western diet, and food's obviously very important to me. But are we seeing similar trends in terms of younger onset colorectal cancer around the world in other countries?
So where we're seeing it most is Japan, China, and the United States are the top three countries with the steepest rises. But we're also seeing an increase in the incidence of colorectal cancer in the young in higher income countries. So Australia, United Kingdom, Canada, and Germany.
Yeah, that's kind of interesting that it's happening across the globe. It's really, I'm very, very curious what risk factor epidemiology is going to show us. In these studies, we're not looking at which drug is better, but we're looking at what are the risk factors for developing disease. And that's really important to do for this patient population. I think we should wrap it up here. We talked about a lot of good things. And one of the questions that I had for you, and I'm sure maybe Ronak or Dan have a couple of wrap-up questions, but I'll do my wrap-up question. So it seems like you're trying to start a young adult cancer program at Fox Chase. Can you tell us a little bit about that and what that takes and what the steps are? Because I'm sure there's a lot of listeners who might think about doing that in the future.
Absolutely. And I think it's something that, if possible, and obviously if the means are there, is that every institution that should have a young adult cancer program. And what I mean by that is young adult cancer programs are designed to try to focus on patients generally between the ages of 18 to 39, and sometimes we extend that to 18 to 49, because there's differences with the psychosocial financial implications of their cancer diagnosis relative to those of more average age onset. So, for example, one huge topic is fertility with our patients. Those are of average age onset in their 60s, generally speaking, are done having children, have families that are grown. So that is not necessarily something that they are not worried about as much. But those who are diagnosed in their 20s or their 30s, fertility is a huge issue. And so having programs that allow more streamlined access to fertility care or more streamlined access to financial counseling for those that may be still in college, those who are early in their career and have a lot of student loan debt, that they're saying, oh man, how can I deal with a cancer diagnosis and the cost related to treatment and handle all this debt and all these things? So it allows patients to have more streamlined access to supportive care services from multidisciplinary way of psychiatry, social work, financial counseling, fertility, so that the goal is to improve the overall care of these patients. And a lot of these programs as well will also try to help focus on the research component. And so helping to have young adults enroll in clinical trials or try to understand why this rise in early onset colorectal cancer or the rise in early onset breast cancer is occurring. And so it's one of my big goals is to, if I can provide at least some difference in these patients' lives for the better, to make their cancer journey a little bit easier, that is 100% a win. And hopefully a lot of other people around the country can try to do the same.
That's incredibly admirable. And I'm so happy to hear that things like this are happening. We at Rouleau are lucky to have a program that's like this, but it's very evident that this is not the case everywhere. One of the things that, whether or not you have a clinic like this at your institution or not, with this rise, there's a likelihood that any of us may see patients like this in our own clinics. And so you touched on fertility preservation, which is such an important topic that we honestly don't talk enough about. Could you talk to us about, how you counsel patients that come to your office when they're younger with this new diagnosis? Maybe even comment on things like sexual dysfunction and things like that, other common questions that young adults may have for you, and how we as their physicians can provide answers for them.
And, it's a great question. And Ronak, I appreciate you bringing up the fact that I think a lot of oncologists, we're rushed for time. We're trying to make sure that we get to see all of our patients and give them the best care we can. And sometimes we forget about certain things like fertility and counseling patients of these younger ages, of these different things that may not be as prevalent in those of the average age group. And so one of the things I try to do, and sometimes it does take a couple of visits because of the time allotted, but trying to understand not just to have them understand their cancer diagnosis in and of itself and the implications for them and their family and their children, which in and of itself can be an astronomical thing to handle, but also taking the time to address the psychosocial issues, the financial things that they potentially are going through, and the fertility issues. And so I think one of the important things that I try to do is with each visit, focus on one or two aspects of their care outside of their specific cancer diagnosis in and of itself, the treatment, the toxicities, those types of things, to focus on things that are outside of that, such as how are their children coping with the fact that their mom or dad have a cancer that's affecting their lives. How can we help them, the children and the patient themselves, discuss this with their children, or is there counseling that potentially is needed to help the children understand the concept that their mom or dad may have an illness that is terminal. And so I think from a counseling perspective, it's really just taking the time to recognize that this is a multifaceted approach to care that all patients in general should get, but young adults have some unique difficulties that we need to address and really try to focus on.
I love that answer so much. And these are just such great reminders for all of us that are listening. And Chris, I was beaming as you were giving that answer because, I mean, you were one of our co-fellows not too long ago, and it's really cool for you to take that same genuine bedside manner that we saw when you were a fellow and taking that over to Fox Chase now. And your patients are so lucky to be able to see someone like you that has the insight to even know to ask questions like that. I think, the work that you're doing is certainly phenomenal. And as I mentioned, you're so early in your career and you're already getting a lot of recognition for this work, and you completely deserve it. So I'm really excited to see sort of where your career takes you from here. This is just the beginning for Chris Cann. Y'all watch out.
No, I really appreciate those kind words, but honestly, it's the colleagues like you that really helped shape, the ability for me to do these things in the first place, honestly. So, because we all learn together and we all support each other. And so recognizing the things that I can improve on, things that we're all really passionate about, and supporting each other along the way has been great. So I really appreciate all three of you. So.
All right, guys. Well, any final thoughts that y'all have?
Now, one thing I just want to add, Chris and I we residency together, fellowship together. I didn't think he was going to get this professional. You know what I mean? This is, I didn't, I don't know. I'm proud of him. I'm proud of him, but I didn't think either of us were going to get this professional. I didn't think it was going to happen. But looking back at our intern year when we hung out and had the group gatherings and did the things that we did. I'll leave it at that.
Somehow we made it through.
We made it through. And
now look at us. Everyone's doing great. So, and you guys put this podcast together that has done absolutely phenomenally. And to let you guys know, a lot of the people that I work with at Fox Chase know of your podcasts, and a lot of the fellows listen to it. The education you guys are providing to everyone across the country is sincerely profound. So, great job.
Well, thank you.
Yeah, thanks.
All right, guys. Well, Chris, before we wrap up, I'll let you have the final say. If there's anything you'd like to say before we close out.
I think that this early onset colorectal cancer, although we don't quite know the underlying etiology of what's happening, that may take some time. But what we can do is try to impact the lives of each of these young adults that come through our door in our clinic, and try to help them in the ways that they may be too afraid to ask about, such as fertility, sexual dysfunction, how to handle the financial toxicities of a colon cancer diagnosis or any early onset diagnosis. And so just recognizing that these patients may have some more unique needs, that we can really try to make a difference in their lives for the better. So
absolutely love that, Chris. And it's super important for any specialty that we do. For Hodgkin lymphoma, I see a lot of those patients. It's so important for anyone in HemOnc to really take what Chris was saying and really take that home and really think about all the things that Chris said. So great episode. And I think that wraps it up for a great episode today. We'll see everybody next week.
See you later.
Peace.
Go Birds.
go birds.